everybody. Welcome back to another episode of The Skeleton Crew. I'm Jen Callahan, your host. And tonight and today, where she currently is, I have a great guest, Dr. Sally. She is a dual-trained radiologist and also a nuclear medicine specialist. So two great things going on right there. She's located in Sydney, Australia, and she's taken the time out of her Saturday afternoon to be with me tonight on Friday, where I am. So thank you so much, Dr. Sally.
No, and thank you so much, Jen, for inviting me along. It's a real pleasure to be part of the podcast. So thanks so much.
Yeah. So I named two different things that what your profession is. So can we kind of start there? What are you currently doing? And then maybe just lead into how did you get to this part in your life to be trained in two great things?
Yeah, I'm actually kind of surprised I ended up here myself, to be honest. But in Australia, so we're a little bit different to North America. After medical school, we do a couple of years of general training and then you will specialise. Clinical radiology is a 5-year training program in Australia, which you do to become a radiologist. And then nuclear medicine. Interestingly, you can become a nuclear medicine specialist through a pathway of being a physician. So the same way that we train cardiologists, gastroenterologists, but also through radiology. So back when I was in medical school, I had absolutely no idea I wanted to do radiology. I had never met a radiologist who had a kind of looked like me, but I always loved physics and I love science, and that kind of part of medicine really spoke to me. So going through my years post becoming a doctor, I started to get a little bit more involved. I really liked radiation oncology for those reasons, but found it just really wasn't for me. And then ended up finding radiology. And it was completely by accident because in Australia as well, radiologists and radiation oncologists are trained through the same college. I'm not quite sure why. I think it's got some historical origins through that way, but we share a conference. And so I ended up going there interested in radiation oncology and stumbling into a head and neck radiology lecture and falling in love with it. So, which was amazing. So that's how I ended up pursuing radiology. And in the year before I got onto training, I ended up in a nuclear medicine job, kind of getting a little bit of imaging experience, beefing up my resume to try and get onto the radiology training program. And ended up coming back after I finished my radiology exams 4 years later to come back and do advanced training at the same department. So I ended up qualified in both. I still work at that nuclear medicine department. Was there and then went away for 5 years and then came back and did my training. I'm there at Royal North Shore Hospital in Sydney, 10 years later. And I also work as a specialist radiologist at clinical radiologist in the Central Coast, which is probably about an hour north of Sydney for those who know Australia, which is near the coast, near the beach. It's very beautiful. Yeah, and I also do a little bit of academic work at the University of Sydney as well. So I'm a bit of a mismatch, but I really like teaching. I supervise registrars. I get to teach at all levels, all the way from medical school right up to fellow consultants with some of the other things I do. So yeah, I really enjoy it, and that's kind of how, in a nutshell, is how I ended up where I am today.
Yeah, that's a lot. Wow. So a question for you, nuclear medicine specialist, are you specializing in looking at the imaging for nuclear medicine?
Yes.
And then do you
that's
also
right.
too possibly help with the exams?
Oh, that's a great question. And I have to say, there's a lot of overlap in what we do, but there's also a lot of misconceptions about where the technologists, the nuclear medicine technologists, and even the radiographers, where we stop and the radiologists begin. Primarily, my role is in interpreting the images, but we also have a role in patient assessment. Usually it's the nuclear medicine technologists who administer the tracers, but in some of the procedures, which involve a little bit more kind of clinical involvement, we also do, assessing the patients. We do cardiac stress testing. So as we are doing that stress test, it's usually myself or my registrars who are giving the radioactive tracer at the time to get a snapshot of the blood flow to the heart. We do something called lymphoscintigraphy with the injection. I do the injections where you inject under the skin for breast cancer patients or patients with melanoma, for example, looking for sentinel nodes or looking for lymphatic drainage. That's something I do. But the technologists, they primarily do a lot of the tracer injections. But, the communication between and our teamwork is just so important when it comes to this because, they'll be greeted by one of our techs who will pop them in the room, get the cannula in. Myself or the registrars will come and say hi, take some clinical history. And that's really one of the great things about nuclear medicine compared to diagnostic and clinical radiology is you have that patient interaction, and it varies. Sometimes we see patients very briefly, sometimes a bit more. And because we do treatments as well, you've got that it's kind of almost that you can see the physician's roots of the specialty there with that patient contact. So we'll go in, we'll have a chat with them, flag any issues. So for example, if we're doing a bone scan. We'll ask them if they've had any recent fractures, where their pain is, if they've had any surgery, pins, plates, metal hardware, that kind of thing, if they're coming in to do a PET scan, so particularly for our oncology patients. And my subspecialty interest is a lot to do with oncology. So say if a patient comes in we're doing a PET scan for a lung cancer, I want to know, is this the first time you've come in? Is this a new diagnosis? Have you had chemo? Have you had surgery? Have you had radiotherapy? How long ago was that? Because all of that information is so important in reading the scans and giving the patients and the referrers the best and most accurate information. So yeah, like we're a team pretty much. A lot of the kind of the very technical stuff, the quality assurance is done by our technologists, but we kind of have a supervisory role. We'll check the scans, report the scans, communicate with the referrers, and we all form really equally important parts in the patient's journey, along with a whole lot of other people, secretaries, physicists, radiochemists. We're a big
Right.
department. Yeah.
So you do the injections and you're part of that. As part of nuclear medicine, you're also doing readings on things like PET CTs and PET scans and things like that?
Yeah, definitely. So I guess every single department's different. So to have the qualification to read PET scans, to interpret them, in Australia, you have to go through the nuclear medicine training pathway, in addition to either physician training on clinical radiology. So yeah, like in our department, we'll have one specialist we roster to nuclear medicine, and then depending on how well staffed we are for the day, which is always how it is,
Yeah,
one or
right.
two senior doctors who'll be supporting the registrars. Because we're a training site, we'll often get the registrars to have a look at the scans, or we'll look at the scans together and they'll pop in a report and we'll change them up, or we'll both tackle the list and try and get through the patients as it goes through. But we try and kind of keep that as collaborative as possible. But yeah, PET is a huge part of what we do, and it's such an emerging modality. It's no longer just about oncology, so cancer patients now as well. There's so many applications. We do a lot of dementia imaging, that like infection. So there's been a move towards the more traditional. We would do kind of bone gallium or bone and white cell scans, which is general nuclear medicine. And now a lot of our patients who have bacteremia, so bacteria in the bloodstream, or sepsis, may come down and they might have a PET scan for that now, which, because the scans are so much quicker, the dose is less, they've got beautiful resolution, the images are just great. And then, we do vasculitis scans, which are just so useful for patients with giant cell arteritis. And potentially we can save these patients biopsies, which the temporal arteries up here, which can be quite invasive and even a little bit disfiguring. So there's so many different ways that we're branching into it. And there's so many different new traces which are emerging. And that's one of the really exciting things about nuclear medicine, is it's so rapidly evolving. And it's not just a one tracer for every single cancer or infection study. There's, more than you can count. And even in PET, while we've traditionally used things like FDG, which is, radioactive sugar, we do a lot of imaging for prostate cancer patients with a tracer called PSMA, or prostate-specific membrane antigen, as well as patients with neuroendocrine tumours, which are a rare subset of tumours which have been traditionally quite difficult to treat. And we use a tracer called gallium-68 dotatate for those patients at our centre. And, being able to give options for imaging as well as, pairing these with therapies, it's just completely revolutionized things. And it's such an exciting part to work in.
Not only are you a radiologist, a nuclear medicine specialist, but you also work in academia at Sydney University. So that's awesome. Is there a particular topic that you teach, or a specific class that you teach, or you kind of just hodgepodge like you kind of are in your profession?
It's well, I guess it is a bit of a hodgepodge, actually. Yeah, so I started at Sydney University back when I was working in a different hospital in the centre of Sydney, Royal Prince Alfred. It's right next to the Sydney University campus. It's a very big hospital. It's probably one of the older ones in Sydney. It's a lot of tradition. It was a great place to train. A lot of really, really interesting pathologies and very senior doctors. So I started there after I finished my radiology exams, and I was asked to come on board and help out with designing a master's unit of study. And what was really interesting about this master's unit was it was for doctors who weren't radiologists. It was for clinicians like general practitioners, I think you call them family doctors in North America, ICU doctors, physicians of different specialties, how they could improve their medical imaging skills. So I started getting involved with there, and from that I got involved in another unit that was already established, which was aimed at improving medical education for surgeons. And a lot of what we did, as you say, it is a hodgepodge. It's across many, many different disciplines of radiology. And we threw in some nuclear medicine there as well, because it's so important that we complement each other, and looking at those things that are going to be, high yield and relevant for surgeons, for physicians, for family doctors, in terms of improving their, not only how they interpret medical imaging, but understand it. How do they talk to the patients in the community? If you're sending a patient for an MRI of the brain and they're pregnant, what things do you need to talk about? That kind of stuff. That's kind of how I started into it, and trying to focus on things, trying to keep in the back of my mind what's important, what's relevant, what's going to be useful for these doctors. From then, 18 months ago, I was brought on very, very luckily. Very happy to be part of the medical school now at Sydney University. We started really looking at how we were teaching radiologists, how we were teaching medical students imaging through the program, and what we could do better. And I think kind of a lot of that is embedded in our accessibility of medical imaging. And, if you teach a first year medical student, or even a first year science student, or somebody who doesn't have a lot of that background knowledge, really high level radiology, they're not going to get it. If you teach them MRI physics, they're going to get quite confused. So we really took it trying to take a step back and go, well, what's important as a first year? What are the basics? What do we want you to know? What's a CT? Why is it important? What is radiation? What are these things that are going to fit into the patient journey? So kind of starting with that. And so this year, I've been focusing a lot on fundamentals, just a lot of real basic things. What does a fracture look like on an X-ray? Yeah, you can point at it and go, yeah, there's your problem. But what else? Does it go into the joint? How is this different from some kind of normal variant? That kind of stuff. So we started at a lot of basics, and we're going to work up, got some grand plans for doing a bit more about, imaging pregnant women and pediatrics, just so we can give these medical students the skills to be functioning interns and improve their patient care and integrate medical imaging safely and effectively. And I do get to go and lecture the radiographers as well at Sydney Uni sometimes, which I love doing.
So you said that you were doing also 2 classes for clinicians who are already working in the field. And I feel like that's great as well, to aid them possibly. Same thing, in how to explain things to patients and families. And then even, I guess, to aid them in to know what type of exams to order for the diagnosis that they're looking at.
Yeah, and that's kind of when we did the curriculum redevelopment, and now we're with our Master of Surgery unit, we're probably about to go through a bit of a change over the next 12 months, changing our assessments, updating a few of our lectures, because we've had them for, like 6 years now, so it's a good time. But a lot of what I kind of keep in my mind when I'm designing new content or even writing the assessments is what do I want to get? What do I want the surgeon or the future surgeon to walk out at the end of the master's subject? And I want them to be able to interpret basic imaging studies, so CTs, X-rays, with a degree of confidence that they can pick common and life-threatening diagnoses on that examination. And Australia, we've got a lot of remote sites, a lot of remote hospitals that may not have access to radiology overnight. And so I think, look, if I've got a surgical SRMO, so a senior resident, they're maybe 2 or 3 years out of medical school, and they're sitting in an emergency department in Western New South Wales, and there's no one else to call. If a patient has acute appendicitis or a brain bleed or something that needs immediate intervention overnight, can I give them the skills they need to interpret that study safely? So that's the first thing, common and life-threatening diagnoses, so that if they're on their own, they can make time-critical decisions to keep our patients safe. And then the second part, as you say, like having those conversations, giving them the skills to understand how imaging fits into the patient journey. If a patient's got renal impairment, should you consider doing a CT pulmonary angiogram to look for pulmonary embolism, or would you consider a nuclear medicine study such as a ventilation perfusion scan instead? What would be safest? And then also, being able to have those conversations. And if they've got lower limb neurological symptoms, do they necessarily need a whole MRI of their spine, or is a lumbar spine enough? When should we not be giving gadolinium contrast? Who may need sedation? If they're coming in for an MRI, if they've got risk factors like metal fragments in their eye, if they used to be a welder, for example, what do they need to do? All of those kind of practical skills. And I guess the third thing is, I want to make radiology more accessible. I want to make them look at radiologists and go, look, it's okay to call them and have a conversation. And radiology technologists as well, or radiographers such as yourself. Like, I would much, much rather them get in contact with us and ask questions rather than just say, oh, I would like a non-contrast CT pulmonary angiogram and then have to have a conversation with an intern who doesn't quite understand why you can't do that without contrast. That's a very extreme example, but it has happened to me once. What we want to avoid is getting into these heated discussions, which unfortunately does happen when we try to go, look, maybe have you thought about this from a different perspective? But they're like, no, I need this scan. My boss wants this scan. We need to get this scan. And it's like, okay. It's about opening dialogues and just making us more accessible and just showing that radiology, we're a collaborative specialty. We're not just a service where you put in a request and it just happens. We're there for consulting, we're there for growth, we're there to help our patients together. I guess that's kind of, hopefully, we'll see how we go. But it's a continued growth, but that's what we're aiming to do.
This episode is brought to you by xraytech.org, the RadTech career resource. If you're considering a career in radiology, check out xraytech.org to get honest information on schools, degree options, career paths, and salaries. So you obviously teach to a big audience. You're doing students and then you're doing clinicians who are already in the field. Is there a teaching style that you've kind of come up with at this point that you feel like can address both groups and something that you have found is received well, I guess?
It's such an interesting question because we're all so different, aren't we? And I always kind of get back to thinking that we're not taught to be educators. Like when you're training as a radiographer or a technologist, you're not taught how to teach. And the same with us doctors. It's just something that we've been expected to be able to do. In terms of kind of we're doing a project at the moment, looking back at the feedback from our units of study for our masters, so our doctor students, looking at what they like in educators. And the things that kind of keep coming up and coming through is you want somebody who is enthusiastic. And that has to translate through whether you're sitting next to them, whether you're sitting at the front of the room, or if you're trying to convey it through an online video, which often is not as easy as it sounds. Like you've got to be a bit more of a little bit more amped up version of yourself because you may not have your facial expressions, you lose body language, that kind of thing. What I've always found works best for me, regardless of who I'm teaching, whereas it's other doctors, radiology trainees or radiology residents in America or junior doctors outside of my specialty or medical students, they really do get a sense whether or not you know what you're talking about, if you know the subject matter, and that makes you more comfortable in bringing it through, but also that you like what you do. And, which can be really hard some days if you've had a terrible morning and your reporting list is out of control and you may have had a difficult interpersonal reaction that morning, trying to convey that you want to be there and that you value the experience. And I think that's been one of the challenges that I've really kind of sought to address is that the misconceptions there's that sometimes radiology is inaccessible, that we don't want to teach, we see this as a burden. We never ever want to have that across because that's the moment that people are going to stop engaging, they're going to stop being interested and they're not going to want to, keep going with us. So I try and bring that through. I like colour, pink chair behind me. I often teach with pink headphones. I try and make sure that my slides are designed in a certain way. Like I like a bit of color on them, but at the same time, I'm quite mindful that I don't want to make them overwhelming and distracting. And always, if I'm recording videos, I make sure I have a pointer because that can be really tough. Like if you're trying, or, good animations with arrows, because trying to teach through a video, your viewer might not actually know if you're like, oh yes, there is a nodule in the right upper lobe of the lung. They might be going, oh, where? And then the next thing the slide's gone. So you need to really have that interactive part. So when I do my online videos, I'm always very conscious of animations and cursors to indicate what I'm saying, as well as making sure if I am recording, I'm in a quiet environment, my audio equipment is okay, I don't have distracting phones going off, alarms in the background, send my dogs to the park like I have this morning. So that we don't have too much noise, because that can kind of distract from the experience too when you're using that different media. I think also things like Radiopaedia I teach with on and off, and I also do some lecturing for them as well through their conferences, where the ability to use scrollable cases in education has just been a complete revolution in how we teach. And whether that's, a screen capture going up and down, or teaching somebody, whether that be a medical student or a first-year radiology trainee or radiology resident, how to approach a CT of the abdomen. Even some of our radiographer colleagues, showing them how to, scroll through a brain to look for blood, if they need to, if there's a bleed to escalate to the doctor, or to, consider doing an angiogram. That systematic approach and those communication of practical imaging skills is so much more important than just going, here's a picture, here's the abnormality, next slide. It's got to be more than that. It's like, well, here's the abnormality. What can you tell me about it? What does it look like? How big is it? What is it doing to the surrounding structures? What might have caused it? What else do you need to look at? So marrying it into clinical problem solving is also something I like to try and do. At the end of the day, though, a lot of it's practice. Like I'm lucky, super lucky. People ask me to teach. So I get to kind of try different things and see what works and see what doesn't. But at the end of the day, I think if you enjoy what you do, it comes through, and people are, and your learners are going to be really happy to engage with you, and hopefully they might not love the content as much as you do, but they'll certainly appreciate it.
So I wanted to kind of roll into, you had mentioned Radiopaedia. You work with them, you're editorial, but you were also too saying that you use them sometimes to assist in, teaching. So can you explain to us what Radiopaedia is?
Yeah, so Radiopaedia is an online, open source, open edit, global radiology resource. And it is probably my go-to resource. It contains, tens of thousands of articles, tens of thousands of cases, and every single edit, every single article, every single case goes through an editorial board. So everything is peer-reviewed. It really has, over probably the last, decade, has just emerged as one of the leading radiology educational resources around the world. And what's great is it's free to access. There are some courses and content which you can subscribe to as well. But that's one of the other great things that is the philanthropic kind of angle of it, is that while there's a tiered country system, so myself in Australia, we're in tier 1, so we will pay a subscription fee to access these courses, whereas if you live in a lower socioeconomic country, you can access the resources for free. So, if you're in a country that might not have a huge amount of budget, or they're resource poor in terms of health, you can access, world-leading radiology education for free, which I think is really fantastic. So it's something I think, members in and subscribers in countries like America and Australia can give back, which is really, really cool. So I first engaged in Radiopaedia when I was training as a radiologist back when I was learning, and that was kind of in its infancy. What's really cool about it is, and makes me very patriotic, is that it was originated in Melbourne. So Professor Frank Gaillard, who founded Radiopaedia, is a radiologist in Melbourne, in Victoria, in Australia. And he started it as a way to store his study notes and his cases when he was going through, and so he could teach, and pulling other people initially from his colleagues in Melbourne, and then from all around the world. So it's now this huge global community of radiologists. One of the highest members of the editorial board is a radiographer from Brisbane, Andrew Murphy, who's so passionate about radiology education. We've got on the editorial board, there are neurologists, there are training orthopedic surgeons, there's medical student pathways, junior doctors. So it's just this global community for people who are coming together to build this peer-reviewed, really high-quality resource for people who love to practice radiology. My medical students use it. If they, they're beautiful summaries, they've got beautiful illustrated examples of anything you want. Like, it can be something as simple as a distal radius fracture to something as complicated as a metabolic disorder of the brain on an MRI. Everything is scrollable if it's cross-sectional and curated, and it's a really phenomenal resource. And I was really lucky to get involved. I always said when I was studying for my exams, when I qualified as a radiologist, that if I got through, I would have to join Radiopaedia to say thank you, because I was using it for free at that point. So then I joined, and I got in contact with the academic director and then more members of the editorial board. And when COVID came through, it left this real vacuum for radiology education in Australia and around the world. We lost our ability to sit next to each other and learn. And so they started doing virtual tutorials, using their scrollable online cases and their learning, linking them to articles, bringing, educators from Australia, from the UK to everybody. And then they launched their very first virtual conference in 2020. And they asked me to come on and do a couple of lectures, one on how to prepare for exams, because I was lucky I did pretty well in my radiology exams. And so we tried to share some of that knowledge. And then also on bone scans, so getting a bit of that nuclear medicine knowledge out there. And I've been involved with them ever since. So I have to say, I don't edit as much as I should. I'm a bit naughty, but I am convening the conference this year. So I am still pulling my weight, I hope. So yeah, and the conference is still going strong. We're really excited. It's 5 days of full online learning. We try and get online. We build the buzz. There's even posters now, and the way that it's just grown has just been incredible. I'm so honored to be part of this group of educators.
So one thing I also too want to go over is that you also too kind of partner with Siemens, and not that I so much want to talk about Siemens, but that you do guest speaking, or that you recently did, and was about nuclear medicine, about CT and about PET, and that seems really exciting.
It was really very cool to be asked. I think when you get asked by a company like that, I personally wise, I felt pretty chuffed and I was pretty honored by it. And it was a great opportunity to kind of really consolidate some of the work I was doing in lung cancer. That's kind of the area of clinical radiology and nuclear medicine that I find most interesting. I sit on the lung cancer multidisciplinary team meetings for the Central Coast and for Royal North Shore Hospital in Sydney, which I think you call them tumour boards in North America. It was a really nice way to kind of actually also reflect and build resources. So I recently for Siemens did a full day teaching about lung cancer, different facets. So talking about pulmonary nodules, what do lung cancers look like on PET, on CT, how do you stage, what is your what is the important information that your referrer wants to make decisions. So going back through and taking the time to collect cases and also updating my knowledge. And I think that's one of the real, when you do teach, it's a great opportunity to refine your own knowledge. And sometimes, you never like to see it, but occasionally you go through and go, oh, I haven't been doing it that way. I think I need to change my own practice. So it's a great professional development exercise. So that was really great. It was only for a small group, but because we've got lung cancer screening coming in Australia within the next 2 years, there is certainly an interest in upskilling in terms of how we assess lung cancer and how we think about pulmonary nodules. And look, it was a really cool thing to be asked to do. And I was asked by an old friend who I knew when I was a teenager. We went to science camp together, and now I'm a radiologist and she works in education, a former radiographer who now works for Siemens. And so it was just wonderful to reconnect with her. And I think that's one of the great things is, opportunities like this bring together people into your community, and you get to work with some really fantastic individuals across different specialties and facets of medicine. And look, I really enjoyed it. So, they might ask me back again. So that'd be good.
Let's roll from there into, so many different great developments have happened throughout radiology and, with radiation and nuclear medicine and stuff. Is there anything that that's coming up, I guess, in the world of radiology or nuclear medicine that you're excited about, or that you know of, or that maybe who you currently work for is going to be implementing?
Oh, there's so many cool, exciting things. I think I'll stick with nuclear medicine just because I think that the evolution of things at the moment is, going so quickly, and it's such an exciting time. And what we're kind of witnessing, particularly over the last 10 years, and it's increasingly being implemented into clinical practice, is something called theranostics. And theranostics is when you have a radio tracer that you compare, or you have a pharmaceutical that you pair with one radioisotope that will give you the imaging, so it will give you your PET scan, and then you can swap it out for another one that will deliver targeted radiotherapy to those cells. So we're using that a lot with our neuroendocrine tumours, so there's rare tumours, as well as prostate cancer. And we're really, really lucky in Australia, some of the world-leading research groups and clinical groups for PSMA therapy for prostate cancer patients. A lot of that's coming out of Melbourne, as well as St Vincent's Hospital in Sydney. We've got some incredible trials which are promoting this therapy. So essentially they'll have their PET imaging demonstrate where you've got a much, much more sensitive and specific evaluation of where the metastatic or spread prostate cancer is, whether it's in the bones, the lymph nodes, outside of the prostate. And previously, it was quite difficult to treat a subset of these patients that had escaped conventional therapy because these tumours weren't particularly sensitive to conventional radiotherapy or chemotherapy. Okay. And now all of a sudden, we've got these pharmaceuticals that can attack these cells on a molecular level. They'll bind to a specific part of the cell and they'll sit there and deliver radiation within a couple of millimeters to where it needs to go. And, the therapies don't always work, but there's certainly really good results for a group of people, or even just slowing things down, giving people better quality of life, improving pain. With that coming particularly out of the Melbourne group at Peter Mac, led by Professor Hoffman down in Melbourne, it's really exciting. And there's a whole lot of new tracers like F18, FAPI, so the fibroblast activation, which has demonstrated, it's another tracer which is coming out, which is hopefully there's a lot of promise for it changing how we image lots of different cancers. That the traditional PET scan that we use for the glucose, so FDG, which is our normal PET tracer, the issue with that is it goes to the brain. So you can't swap that out and give someone radiation therapy if you're going to irradiate their brain. That's just not going to work. So, but this new tracer takes the brain out of the equation. So all of a sudden now we're thinking about, can we use this to treat a whole plethora of different cancers? So, it's a watch this space. I think targeted molecular therapy and a lot of what we're doing with looking at the genetics of certain cancers, I think that's where a lot of the growth is going to be. And, as an oncology radiologist and nuclear medicine specialist, I find that really exciting.
Well, on that note, we're going to say good night or good day.
Good day.
It's daytime, I'm nighttime. Dr. Sally Ayesa, thank you so much for taking the time today to speak with me and to go over the wonderful world of nuclear medicine. I hope everyone enjoyed our conversation, and check out this episode and past and future episodes on YouTube, Spotify, and Apple Podcasts. So this is Jen and Dr. Sally. Thank you.
Thank you so much.
All right, everybody. We'll see you later. Have a great night. You've been watching The Skeleton Crew, brought to you by xraytech.org. On the next episode, join us to explore the present and the future of the rad tech career in the field of radiology.